I just want to welcome everybody to our information event today. My name is Aoife Kerwin and I am the Information Officer with MS Ireland. We're delighted to host this event in Donegal. It's a very important place for us to host this. As we know, Donegal has some of the highest incidence of MS in the country. And providing accessible information is of incredible importance to us, and we understand that being given the opportunity to hear directly from the experts and to ask the questions that matter to you is really, really vital. We'd like to thank Novartis for supporting the event. With an event like this, obviously there are costs incurred, and Novartis have very kindly supported us with those costs, but have had no input into the information that we are going to be presenting today. I'd also like to thank my colleagues, Catherine, Maria and Geraldine in the Donegal team, who've been absolutely fantastic in helping to organise this event. Just in terms of housekeeping, I just want to let you know that there are restrooms located just on the left-hand side, and there's an accessible restroom also. It's just out the door to the left. MS Ireland staff are all in red t-shirts, so you can easily identify us, and if there's anything you need, we're more than happy to help. We have a photographer here today as well, so if you don't want to be in a photograph, if you'll just let the photographer know, just raise your hand or just let them know that you wouldn't like to be in it, and that'd be great. I do have some unfortunate news. So unfortunately, one of our speakers, Bill Vaughan from Mental Health Ireland, isn't able to make it today. So we want to apologise to you for that. But very kindly, Dr. Kevin Murphy is here, and we're thrilled to have him. And it means, I suppose, we'll have a little bit more time with him today, which we're delighted about. So our apologies again for that. And then really finally, I'd like to thank Dr. Kevin Murphy for making the time to come today and for the preparation that's gone into his presentation. We really appreciate it, and we also know that a Saturday morning is, it's precious time, so we do really appreciate everybody coming along to the event today, and also to everybody who is joining us online. Very much appreciated. I'm going to hand you over to my colleague, Maria Keegan. Great. Thanks so much.
Thanks, Aoife. Thanks, Aoife. Good morning, everybody. Many of you probably know me already. Maria Keegan, I'm one of the community workers here in Donegal, along with my colleague, Catherine Peoples. And our admin, Geraldine, is floating around there somewhere. Thanks, Aoife. Unfortunately, as you heard, one of our speakers is unable to attend. So Dr. Murphy has very kindly agreed to give a longer presentation. And there will be also be an opportunity for Q&A or questions and answers at the end. So I'll just introduce Dr. Murphy. Dr. Kevin Murphy has been a consultant neurologist in Sligo and Letterkenny University Hospital since 2008. For more years than he cares to remember, I'm sure. He's a graduate of the University College in Cork. He has undertaken further training in Cork, Boston, Philadelphia and Beaumont. Dr. Murphy also spent 4 years working in Africa and has a particular interest in tropical neurology. So without further ado, Dr. Murphy, we'd like you to take the stage. Thank you. Moving slides forward.
Thanks very much. Thanks Maria, and thanks Aoife, and thanks to MS Ireland for inviting me to talk here this morning. I'm not sure it's a great advantage to you all if you have more time with me rather than the second speaker, but here goes. Maybe I thought I'd put together too many slides, but first of all, as I say, I'd like to thank MS Ireland and acknowledge the great work they're doing. As Maria mentioned, I'm based in Sligo, but we cover Donegal, Leitrim, Sligo, plus West Cavan, North Roscommon, North Mayo, a bit of Longford thrown in as well. So it's quite extensive. We don't have enough. I'm going to start maybe with just pointing out that fact. We don't have as many neurologists in the Northwest as in other parts of the country, especially Dublin. And I'm not going to be like Jackie Healy-Rae saying bad old Dublin is sucking up everything, but I do think we need more support in the Northwest. First of all, 2 weeks ago was National Brain Awareness Week, and this was, I don't know whether you were aware of that. And that's every year there's a National Brain Awareness Week, and Neurological Alliance of Ireland coordinates it. MS Ireland is part of Neurological Alliance of Ireland, and obviously the NAI, as their summary, as they're called, they are constantly advocating for more services, more resources for people with neurological conditions, and I have to acknowledge their work as well. And they've been instrumental in getting MS nurses, movement disorder, Parkinson's nurses, epilepsy nurses, etc. We need their take-home message is that we need more resources as well, and as well as research and prevention. Can you hear me? Okay. Can you hear me without it? Okay. All right. So that's just to acknowledge their work and say, like, we're sorry, MS Ireland, you're 2 weeks late. Should have had this 2 weeks ago. Sorry. Or a week ago, sorry. No, that's fine. Anyway, there's the numbers of people with neurological conditions, it's every, I've been giving talks like this for a few years. The numbers are going up and up. Population is going up and up. So that's the latest figure, approximately that number of people with neurological condition. And consultations in general practice, about 1 in 8. And the figure that's always quoted us in the emergency department, about 1/5 of presentations are with neurological symptoms of various types. So it's not just like neurologists, realistically neurology, doctors, etc., cannot see all of those, and there has to be an awareness of neurological conditions, among others. But patients with neurological conditions require long-term follow-up and multidisciplinary input. Migraine, of course, is the most common. Epilepsy is also probably the second most common. And then there's multiple sclerosis. Again, the figures, approximately 10,000 in Ireland. How many of them are in Donegal? We don't know the figures exactly. We would have 800 bordering on 900 in our incomplete database in Sligo. So you could have 1/10 of the people in this area. So, and we all know from an MS point of view, we don't know the cause of it, but we know that there's a very high incidence in this part of the world. Michael Hutchinson, who is now retired consultant in Vincent's, he looked at, must be 30 years ago, a study comparing Donegal, South Dublin and Wexford, and Donegal was by far the highest. There's been other follow-up studies showing, for example, the vitamin D levels were lower in Donegal than in those other two populations. We still don't know the cause of MS. We know there's probably a genetic disposition and an environmental trigger, and this leads to some sort of disorder of the immune system, resulting in an autoimmune attack upon your own nervous system, if you like, the brain and spinal cord, especially in myelin, and resulting in loss of neurological function. Again, that's the pathology. That's a fairly simple side. I won't go into it too much, but the myelin is what coats the axon, as we call it, and that's what's affected. But you also, in MS, with enough myelin damage, you get axon damage as well. And MS, of course, is a whole spectrum of conditions. A lot of the time, we talk about the invisible symptoms of MS, the ones that are under the tip of the iceberg, so to speak, and that may account for the majority of symptoms. It does, and maybe the more overt symptoms are the ones above the tip. So we're all familiar with the sort of DMS relapses that can occur. both recognized and unrecognized, and other symptoms which can reflect progression. But underneath you have a lot of subclinical symptoms. You have symptoms obviously like fatigue, maybe cognitive dysfunction, which can happen as well, which isn't recognized a lot of time maybe to the rest of the world. So that's part of the invisible symptoms. But also when we follow up now with MRI scans, etc., we may see new areas on MRI scan that, again, the person with MS is not aware that there's anything going on clinically. So that's all part of the hidden, under the water, so to speak, symptoms. In general, our neurological reserve does decrease as we get older. The bottom picture here, this part, this is a diagram you might be familiar with. It's these boxes here refer to, well, that would be a relapse. In the early stages you would get right back here, but then sometimes a relapse, there's incomplete resolution. But what can happen over time is that relapses may get less or are not as severe, but there can still be some progression underneath. It's not inevitable that you get progression, but it can happen and can be insidious and sort of not apparent day to day, but apparent maybe year to year. And again, the importance of early treatment. This shows the area in green would be the degree of acquired disability, if you like, is better when there's earlier treatment, earlier diagnosis, and therefore earlier treatment. And there's been a bit of a sea change, really, in our approach to treatment in the last 15, 20 years. So we mentioned where you're from is the risk for developing MS. Smoking is probably a slight increased risk of MS, but it wouldn't be the major one. Obesity in adolescence, I'm not sure that's a major one, but low vitamin D levels is probably more significant. And exposure to Epstein-Barr virus, and that's kind of in the last, that's always been around there about Epstein-Barr virus, but there's been some studies in recent years. This was a big study done looking at army recruits in the US, and they really found a very, very strong association with Epstein-Barr virus, almost to the stage where I say that Epstein-Barr virus is the cause of MS. Now, I don't think we can be that categorical about it. And Epstein-Barr virus, and this is an interesting, I'm not sure if this is the actual case, but it's Epstein-Barr virus is the cause of the virus in glandular fever, which is the so-called kissing disease. And teenagers, they get it, whether it is from kissing, I don't know, but and obviously glandular fever can be a self-limiting illness, but that's probably the time we acquire it in this part of the world. Whereas in sub-Saharan Africa, children get Epstein-Barr virus, and it's associated with things like Burkitt's lymphoma, which is a nasty childhood cancer. But you don't tend to get MS in sub-Saharan Africa. Now, you have a lot of other challenges from a health point of view, but could be that that they get it, they're exposed to Epstein-Barr virus earlier in this part of the world, and therefore they're protected in some way from MS. So obviously, a corollary of this is that, there may be moves, and there is a lot of thinking about it, but it's not in practice yet, about vaccination against Epstein-Barr virus as public health policy in future. That slide just refers to all the findings in that study. So we're often asked about what type of MS I might have or a person might have. This is everyone's MS is different. That's the first thing I need to say. And a lot of the time, and most people don't fit neatly into boxes in that regard. But traditionally, we've had relapsing, remitting multiple sclerosis, which is MS is heralded by the onset of a set of symptoms initially. Very often, for example, is optic neuritis, which with blurring and painful eye movements and blurring of vision in one eye, which generally resolves, but that is the symptom that often alerts us to say, could this person, usually young people, could this person have multiple sclerosis? And that, and then we go doing MRI scans and investigate that. Secondary progressive is that after a certain period of time, there's progression of symptoms without necessarily relapses. And so you can, of course, have progression and still have relapses superimposed on it. But this is an important area. Again, I'd like to say everyone's MS is different, but there is definitely another category, primary progressive, more maybe a little bit older in onset, maybe in the 30s, 40s, 50s even, where it's a kind of a gradual onset of symptoms rather than starting with a bang, which is the case in younger patients with relapsing remitting. And then there's progressive relapsing, which is really another way of saying there's progression and then relapse is superimposed. But I'd like to emphasize that everyone's MS is different, and a lot of people with MS don't like this categorization, and a lot of people don't as well. There's different sort of graphs showing that relapsing, remitting. The top left one, for example, you know, that's a relapse and full recovery, relapse, full recovery. And this second one is a relapse with incomplete recovery, and then same afterwards. And then there's more the primary progressive, which is a kind of, again, I don't like that term because it means you're progressing. It doesn't necessarily mean you're progressing, but you can be stable without maybe getting better, and you might remain that way for a while, perhaps with progression later on as well. So, so there is a lot of, you know, the ECTRIMS, the research people in MS, are always looking at this, how best to categorize it. And in the end, I think everyone's MS is different. So that's the type of, that's probably the best way to approach it. So what's the general risk of developing MS? About 1 in 500 in the population. A lifetime risk for women, it's about twice as common in women than men. And the risk of a child of someone with MS is about 1 in 50. Now that's, a lot of people with MS ask, what should I do with my children? Should I do anything for them apart? You can't get, once you're born in Donegal, you can't get unborn in Donegal. You can't move to sub-Saharan Africa and get your child born there, you know, so. So it's a difficult question to ask me. You can't do anything really. You just maybe vitamin D. That's the question, whether you should take vitamin D. That's probably sensible, but there's no firm guidelines on it. And again, when you have siblings, you know, in Donegal especially, I meet families with, you know, maybe there's 10 or 12 in the family, and 3 or 4 may have MS. It's not an uncommon scenario. So there's definitely a genetic element, but we don't know what it is. But probably environmentally is probably even more important. And that might be hard for people who have a couple of members with MS in the same family to accept, but that's the way it is. So, as I say, the diagnosis then is of, you know, even now with all our MRI scans and all investigations, diagnosis is still a clinical diagnosis. I have 1 or 2 people on my books, people with MS, who can never, because of, for various medical reasons, they cannot have an MRI scan. So it's almost unthinkable now that you wouldn't have an MRI scan if you have MS, because, so you may do a CT scan, for example, and you mightn't see anything. Most of the time you don't, especially in the early stages. So the history is still, and yet we can diagnose MS in those patients who didn't have MRI scans based on the lumbar puncture and other things, visual evoked responses, etc. So the diagnosis is still based on the history, and there's no single certain diagnostic test. Yeah, other diagnoses need to be excluded, and you know, even the spinal fluid test that we do, where you get all the clonal bands, as we call it, in the spinal fluid. It's not specific for MS, and you need other things to go with it. You can get it in other neuroinflammatory conditions like lupus, for example. What are the possible symptoms? Well, there's so many possible symptoms. It's kind of, it's an endless list, really. I suppose we're all familiar with blurring of vision with optic neuritis, double vision, weakness of a hand, numbness, tingling of an arm or leg, imbalance, spasms, etc., visual problems. So the symptoms on the left of that slide there are more sort of overt symptoms. The ones on the right are maybe less recognized as being potential MS symptoms, especially at onset, because fatigue is common in the population, but it's can be particularly problematic in MS. Bladder dysfunction, etc. Having said that, most of the time, the symptoms present with symptoms from the left-hand side. The symptoms on the right-hand side are more part of the invisible symptoms we talked about, tip of the iceberg, etc. So we used to say about neurology has changed so much in 30 years, but before we used to say a neurologist will diagnose you and then say, there's nothing we can do about it, goodbye. So diagnose and adios is the term we used. But those days are over, thankfully, although we don't have perfect treatments for lots of neurological conditions. Obviously, management you treat the relapses as they occur. Again, exacerbation of MS, a flare, a relapse, we use different terminology. The symptoms of a relapse should really last about 24 hours, or at least 24 hours. The symptom management that's all part of managing bladder problems, fatigue, etc. And then disease modification, which is the big area, of course, where we use medications. Rehabilitation is important as well, and psychological support, psychosocial support, all important as part of the treatment strategies. Just to mention about clinically isolated syndrome, which is a sort of a term we used before. We used it more before. It's kind of dying a death now, this concept. Usually what it meant was you present with your first symptoms, say, of optic neuritis or a weakness of a leg, a weak, numb leg, say, for example, and you get better completely. And from the investigations, well, again, and this really refers to the older days, I suppose, where you get clinically isolated. You can't say at that point whether this is going to be MS or whether it's going to be an isolated episode. Because there are people who get optic neuritis and fast forward the next 60 years of their life, they never get anything more again, So that does happen. But I think with the advent of MRIs being available, etc., MRIing the spine as well as the brain, for example, giving contrast and doing follow-up MRIs fairly quickly afterwards. Even in the absence of further symptoms, you can still make a diagnosis of MS even after the first set of clinical symptoms. So this really, and more happening now as well, the new diagnostic criteria do not depend on you having a second set of neurological events, although we still retain the term clinically definite MS. So it may be a bit confusing, but I suppose it reflects the imperative to treat early, diagnose early and treat early, and that gives the better outcomes, and that's been proven in research. So really, clinically isolated syndrome is now regarded as MS. And there's an even more interesting thing is the radiologically isolated syndrome. You might get concussion, say, on a playing field or a football field, and they say we better do an MRI on you, and you have no symptoms otherwise, and yet the MRI looks like that of multiple sclerosis. And we regard this as almost an incidental diagnosis. But again, research has shown if you follow up these people over time, both by MRI and clinically, they will develop symptoms. So now it's reached the stage where if you pick it up incidentally almost, that you still go and treat it and still regard it as MS. There's another important concept in the treatment of MS nowadays. It's called no evidence of disease activity, or NADA, we call it. And this really puts us a high standard, really, for the treatment of MS, that we need no evidence of disease activity clinically, which is a relapse, no sustained disability progression, and then no new lesions on MRI as well. And we're not saying we can achieve this in everybody, but this is what we should be aiming for. You know, this doesn't take account of progression, of course, which can happen, because sometimes progression happens even in the absence of new lesions or new plaques, as we call it, on the MRI scan. So that concept really has been very important in the last 10 years, especially in our approach to treatment. With regard to treatment, obviously, it begins with diagnosis and the explanation of the diagnosis and what it is and what it isn't. We use steroids for relapses. Usually that's what we do. Sometimes we use intravenous immunoglobulins, and rarely, but still happens sometimes, plasma exchange. So they're the treatment of relapses. And then, of course, there's physiotherapy, occupational therapy, speech and language therapy, and all the allied health professionals involved. And then there's disease-modifying drugs, which we'll talk about next. And then there's management of the other symptoms we talked about: fatigue, brain fog, spasticity, bladder, bowel problems, etc. And we mentioned MS Therapy Centre because we've been lucky in Sligo, and a lot of people from Donegal go to the Sligo MS Centre as well, which was founded over 30 years ago by two people with MS, who are now sadly no longer with us. But they were very ahead of their time, really, in setting up that MS Centre. And maybe we should have one in Donegal as well. Okay, so definitely we should. So what I suppose, coming back to the treatment of MS itself, you know, when we individualize treatment, obviously, to the person in front of us, and it's not like the old model we tell the patient, or sorry, the person with Ebola or with MS, what they're going to do. Now, some people say, like, you decide, doctor, but we like to discuss all the treatments with the person in front of us, and you have to take account age, gender, any plans for pregnancy, etc., any plans for traveling, going to Australia for a few years, you know, or, you know, immigration or whatever. You know, as you take these all things into account, you still try to pick the best one. So the duration, extent of the risk, and the risk benefit, of course. You have to, whatever drug you choose is going to have benefits. Obviously, we wouldn't be giving it, or we wouldn't be recommending it if there wasn't benefits or potential benefits. But then we have to take the risks into account as well. You know, we don't want the cure to be worse than the condition itself. So this would be the cost. Thankfully, in this country, the cost doesn't of the various treatments doesn't really enter into it. In the NHS in the UK, I think there's more tight control over what neurologists can and can't treat, but that reflects maybe that they have more neurologists than we have. And then obviously side effects are important. How do you measure a response? Well, in the end, it's very much the clinical response. Well, are you keeping well? Are you getting any more relapses? Is there any suggestion that the symptoms are subtly in the background getting worse? But there's annualized relapse rate. Obviously, that's like if you got 2 relapses a year before you went on treatment, and you're not getting any now. Disability progression, there's measures like EDSS, which is Expanded Disability Scale. MRI, obviously, MRI lesion activity. And again, it's not that long ago where we started people on treatment for MS, and we said, we don't need to MRI you again now unless you get symptoms. And this is not the case anymore. The problem arises, of course, in that the number of MRIs we need for follow-up. The system isn't resourced to provide enough MRI spaces in the hospitals in this region. It's the same, it's a national problem as well. Brain volume changes, that's probably not measured a lot of the time, but it can be as quality of life, obviously. There's quality of life measures as well, and symptoms like fatigue. And then there's the whole recent data about measuring neurofilament light chains, which can be measured in a blood test now, but could also be measured in spinal fluid. And obviously we're not going to do a lumbar puncture every year to see how your MS is getting on. But that was looking like going to be that for a while, but neurofilament light chain still hasn't come into clinical practice, to be honest. Sorry. So the decision on what we call disease-modifying drug to choose is based on, as I say, all of this: the severity, duration, nature of symptoms, the type of MS, the extent of MRI changes, the age and gender of the person with MS. Past medical history is also very important, obviously. Pregnancy plans, what's the behavior of MS in pregnancy? And again, usually we say the rule of thirds: 1/3 are stable, get better maybe. 1/3 get better, I should say. 1/3 are stable, 1/3 might be worse. In my experience, I think that 1/3 getting worse is a lot less than that. So I think generally pregnancy is well tolerated in MS. But you do have to take into account the effect of the drugs on pregnancy if you were to become pregnant. And also, as I say, lifestyle and travel plans. It depends, especially for natalizumab or Tysabri, as that drug for MS. Your JC John Cunningham. John Cunningham, I'm not sure who he was exactly, despite the name. He was an American, and he got this, I think it was the 50s or something in America, and he got this condition called progressive multifocal leukoencephalopathy. I'm not sure what his risk factor for that was, but they found this virus that was causative of it in John Cunningham, and then they called it the John Cunningham virus, which we now call the JC virus for short. And it's really only come to light maybe in the last 15 years, or approximately 15 years, that your status in any group, if you go on the main street in Letterkenny and check JC virus status, about half will be positive and half will be negative, and that's just the general population. So it's the same with the MS population. They're going to be about half positive, half negative. But if you're positive for it, you cannot, it's too risky to stay on natalizumab long term. Natalizumab being Tysabri. We're not so sure this is a risk factor for the other drugs, for the disease-modifying drugs, for other MS drugs. And it can be, okay, it is a kind of a binary thing. You're either positive or negative. If it's positive, you can be low positive or high positive, and that matters as well. But in general, if you're positive, we don't continue natalizumab long term. But you can still use natalizumab in short term for highly active MS and try and settle it with natalizumab. In general, and this is a trend, there was a policy maybe 20 years ago, even less than that, it's still probably evident to a degree, that you do sort of escalation. You start at the sort of what we call the platform treatments and see if they work, and if they don't work, then you step up to the next level, if you like. So we call that escalation approach. The other approach is that hit it hard and hit it early, and that probably is the predominant thinking at the moment. And of course, it is generally the case that those drugs that hit it hard and hit it early are the quote-unquote riskier drugs from the point of view of side effects. So that's the kind of a dilemma we always feel, and this is why you have to have the conversation with the person in front of you who's just been diagnosed. So it's a trade-off in risk and benefit, and it's a balancing act. We do know that at this stage, that's beyond argument, really, that untreated MS will lead to disability, which can be avoided. So I think no treatment is probably not. And there will be people who say, I don't want to go on treatment, and that's fine, but I think you have to know that you are probably at risk of developing disability, which you would otherwise not develop by going on the medications. Again, when we treat people with MS, we usually now, especially with the higher order, highly effective treatments, they need to be on the participation in cancer screening programs like cervical check, for example, and breast check, for example. We screen them for hepatitis and TB and HIV and all these infections, and we check immunoglobulins, do a chest X-ray, ECG, and all various blood tests. So all this is we're very much dependent. Well, we coordinate that with our MS nurses. We have, at this stage, 3 MS nurses for the whole region, but they are, I'm sure most of you here will know them. They have a regional remit, but they're physically based in Sligo. So, the MS nurses are very central to bringing people along with treatment decisions, etc. So it's an individualized matter. Everyone's MS is different. I like to say that, and I suppose I sort of say this, especially when you're well, you're still well from an MS point of view. And we like to say that we want you to be in a situation where someone you're working with, or maybe your friends even, say, I didn't know you had MS, just like that, didn't know you had dandruff, sort of, that you're well enough from treatment, that nobody knows you have MS. That's the ideal. Now, obviously, I know that's not possible for everyone, and it's not going to be the case maybe over time, but that's what it is. Now, sorry, this is a busy slide, and I just flash it up. All of those drugs, probably hard to read as well. I'll just go through them all briefly. The bottom 3 separate are Vampira symptom management treatments, and then we mentioned medical cannabis as well, just briefly. So I just want to go through these drugs one by one, and again, we're caught between complexity. Obviously, I'm not going to tell everything about all these drugs one by one, but let's go through them. The first drug that came out was beta-furon. Actually, I should have that there. This one actually is the one that came out first, about 93, 94. So it's and these ones are more or less the same family of drugs and came out soon afterwards. Avonex is intramuscular once a week. Like all the interferons, and the drugs have been around for the longest. You can get flu-like symptoms in association with taking the drug, it's not oral, it's never oral, it's either IM, like Avonex, or subcutaneous, like the same drug, but in a different formulation called Rebif. And you monitor liver function tests and full blood count. So that's, Avonex is intramuscular once a week. Rebif is subcutaneous 3 times a week. Beta interferon then is the one that came out first, and that's subcutaneous every second day. So I mentioned the interferons. As I say, 20 years ago, they would have been our first choice probably. They have gradually moved from being first choice. There's still a lot of people with MS on interferons that are doing well, and I suppose it's just a quirk of when your MS was diagnosed. If you were diagnosed 20 years ago, you might have been put on a Rebif, for example, and you've done very well since, and there's no reason to change it if you're doing well from a neurological point of view. Now, a lot of people who were started on Rebif 20 years ago, they may have got further symptoms, and there was treatment failure, etc. So you would change from that. But now, if you presented with MS today, in 2026, we probably wouldn't be going for those drugs because of the different approach. As I said, the escalation was our philosophy beforehand. Now it's highly effective treatment early. So as I said, hit hard and hit early. Glatiramer acetate or Copaxone, which is and there's a new generic one called Brabio, subcutaneous, 3 times a week. And again, that used to be daily injections. So that was a big advance about 10 years ago where the injection burden was fairly heavy with a daily injection. But now it's 3 times a week. I'll mention mitoxantrone, but it's more historical now. This was there before Tysabri and natalizumab, and it's quite a toxic drug, but it was quite effective for felt to be secondary progressive MS. There was cardiac toxicity, and there was also a predisposition to leukemia. So it didn't. It's not really used at all now. But I mentioned it there. There's people still living with MS who may have had mitoxantrone, so I mentioned it for that reason. Natalizumab, or Tysabri as we call it, was really, this was pretty much a game changer, as we say, when it came out. I mean, this drug was initially actually licensed for Crohn's disease, ulcerative colitis, for inflammatory bowel disease. And actually the complications of natalizumab that we all vigilant about is PML, or progressive multifocal leukoencephalopathy. And actually the first patients, unfortunately, who developed PML were actually inflammatory bowel disease patients, and they were not MS patients. But it's no longer used for inflammatory bowel disease. And this was supposed to come out about, I can't say it a year now, it was about 20 years ago, or more probably. It was supposed to come out, and then the PML cases were discovered in the inflammatory bowel disease population. So Tysabri wasn't. It was held for a few years before it was actually reintroduced. So again, the big question, if you decide to go on natalizumab, is what's your JC virus serological status? Is it positive or negative? And if it's positive, again, as I say, if it's severe enough, natalizumab has an advantage that it can settle very active MS with lots of lesions, maybe a lot of enhancement, and it can settle it quickly. So you can still give it to seropositive quite safely for a year or 2, but then we wouldn't continue it long term. It's given once now every 4 to 6 weeks intravenously, and in this area, that's all done in Sligo. It can be given subcutaneously also, but you still have to come to hospital for the subcutaneous injection. It's not at this point self-administered subcutaneously at home, which might be something that'll happen in future. So there is a group of drugs ending with the term MOD, fingolimod, which is Gilenya, and this is a drug available since 2012, and it's an oral treatment. And obviously, a lot of people like that idea. It's an oral treatment. You don't have to come in. You don't have to give yourself sometimes difficult injections, or you don't have to go somewhere every month for an infusion. So it's an oral treatment once a day. There is unfortunately been rare cases, but still cases of this PML, this condition that is we don't really want anyone to get. And there's been we've had a case of cryptococcal meningitis on someone with this in Sligo in the last couple of years, but the patient has done well. And there's also now retinitis, or inflammation of the back of the eye, which can happen with it as well. But it's quite an effective drug, and I have lots of people with MS who are very happy on this drug. It lowers the lymphocyte count again, so there's monitoring involved in that situation. One of the issues with it, if you stop the drug, there's this risk of rebound MS. So it's like you're keeping everything suppressed, and you take away the handle, and it all sort of rebounds. So you can get nasty sort of relapses when you stop it. So transitioning from this drug to another drug, again, the thinking about that has changed in recent times. So you would start another drug pretty quickly rather than waiting for a washout period. This is a first similar drug to fingolimod is called Mayzent. It's eponymous. It's the only drug really, apart from mitoxantrone, that has been indicated for secondary progressive MS. But I think the experience with it hasn't been that it's maybe not as it hasn't taken off maybe in a way which we thought it would, and it's similar to fingolimod otherwise. And this is another drug that is probably similar to fingolimod as well, but we have less data on it. So again, I don't have anyone personally on that drug. Dimethyl fumarate or tecfidera, this is a drug as well that is taken twice a day, and it can cause flushing, and that can be a very rate limiting reason for people not to take it. It can get GI, gastrointestinal symptoms as well. And again, transaminitis, sorry for the terminology, that's liver function abnormality. You have to watch your liver function as well. Low lymphocytes, but not to the same degree as the fingolimod. And again, PML has been described with that. And again, I have people who have on that medication, they're doing well, but other people can't tolerate it, so we have to switch. And again, there's, like all the drugs, sometimes it could be a matter the drug is tolerated, you don't get side effects, but the MS can still be active, or you can still get a relapse. So, and that's because no evidence of disease activity, or NADA is our standard, so to speak. Then we'll switch the medication. This is a similar drug to tecfidera, and there's supposed to be less flushing and less gastrointestinal distress, but otherwise it's very similar. To the other one. Teriflunomide or Aubagio, it's an oral treatment once a day. You can get gastrointestinal diarrhea, it can happen sometimes, thinning of the hair. Again, it's probably the efficacy of that drug is lower than the other couple of drugs I've just discussed. So we don't use it that much, but there's still, again, we have a couple of people on it who are doing well on it. This drug, alemtuzumab or Lemtrada, again, this drug is a highly active drug for MS. It pretty much depletes the immune system. It's almost like doing a bone marrow transplant without doing a bone marrow transplant, if you like. So it's a treatment you give for 5 days, year one, and then the second year, 12 months later, you give it for 3 days, and that's potentially the end of treatment. Sometimes we've given a third dose. It's highly effective. You have to be in hospital for the infusion. There's a lot of rashes, and there's autoimmune conditions associated with it as well. But in the acute stage, there's a lot of rashes, and you can get infusion reactions. This was a drug was doing well until about 5, 6, 7 years ago, when there was talks that there was a risk of stroke at the time of the infusion, especially in North America. This was North American data, and it kind of frightened us a bit. So it has gone off. It's not chosen as much now, and in fact, officially, you're not allowed to use this drug unless you've failed one or the other highly active treatments. Having said that, the people I've had on it have done well on it. Again, there's a lot of blood monitoring afterwards, monthly bloods for 4 years. There's a risk of autoimmune conditions, so autoimmune thyroid problems, sometimes low platelets, and can affect nephritis or inflammation of the kidneys as well. Cladribine, this is another drug where you can reconstitute the immune system like the last drug I mentioned. And this is an oral medication given week 1, and then week 5, year 1, and you repeat the same thing a year later. Again, side effects, and this is a good drug actually, and a lot of people like this concept that you take the treatment and you potentially finish with treatment then. The shingles and rashes are the main things, and again, you get low lymphocytes and that. we haven't seen any PML with it, with this drug from the MS side of things. But this is also a chemotherapy agent, was used about 20 years ago or more for leukemia in children, and there was PML described with that. So we always have to issue caution. Ocrelizumab, or Ocrevus, is a drug that has really taken off in the last few years. It's monoclonal antibodies, the so-called anti-CD20 drug, and it's similar to rituximab, which is a drug that has been around longer and used for various other conditions. Rheumatology use rituximab a lot. So it's an infusion every 6 months, and it will be available subcutaneously in the near future. So that may change again. The duration of the infusion will be less. Complications, infusion reaction, fast heart rate, infection. That's an interesting one, possibly inflammatory bowel disease. Again, this is an area that there seem to be a few people who've been on ocrelizumab have developed symptoms of inflammatory bowel disease. Is this a complication of ocrelizumab, or is it the fact that if you have one autoimmune condition like multiple sclerosis, that you're at risk of another autoimmune disease like inflammatory bowel disease? I don't think that question is answered yet. Possibly PML associated with it, but certainly not to the degree of natalizumab. And then rituximab, I mentioned that because that's used extensively, and there's a very interesting, in the 2 Scandinavian countries, Sweden and Denmark, they've been using rituximab for years in Sweden, and they've followed up the patients, and they've compared it to Denmark, where they didn't use it, and they're similar populations like Scandinavian countries. And the follow-up studies showed us that there's definite benefit to rituximab, less disability progression, less relapses. So, and it's the rest of the world never, I don't know what's single out Sweden to use that. This is another drug, Kesimpta, or ofatumumab, and again, this is like ocrelizumab and the last rituximab. It's the same category, but it's a subcutaneous injection every 4 weeks. Now, when you start it, it's more frequent than that, but maintenance is every 4 weeks. Injection site reactions, infections, possibly PML. Sorry. Okay, so there. That's a quick run through. I'm sorry, I hope I haven't overloaded you with all the drugs that are available. Then we should mention about stem cell transplantation, or hematopoietic stem cell transplantation, to give it its full title. Stem cell is what we use day to day. It's a highly effective treatment, and it literally wipes out the immune system and then rebuilds it using your own stem cells. So it's generally best for younger patients with aggressive, active, relapsing, remitting MS after failure of another highly effective treatment. It's just important to point out that stem cell, if you have symptoms, neurological symptoms from MS, that it's not going to reverse the symptoms or the damage, so for want of a better term, that's been done already. There is risk of infection, bleeding, and death. And so it is a kind of you climb a mountain to reach the other side, and there is a risk involved in it. It's obviously something that's very considered from our point of view. If we have people we think might be a stem cell candidate, we discuss it with a national meeting. We have a national meeting every 3 months or so, 2 months maybe, that we do a Zoom meeting with all our colleagues in the other hospitals in the country, and we present the data of that particular person and get the opinion of others. And then if there's an agreement that there would be a stem cell candidate, we would then refer to London, where there's another referral pathway and another discussion in London, because we don't have the service in Ireland. Obviously, there is stem cell treatment for leukemia and cancer, etc., but not for when it's your, this is autologous stem cells, obviously. It's your own stem cells, so they take out blood and put the stem cells back in once they've sort of wiped out the bone marrow, if you like. So it is not a day in the sun, obviously. We are looking at it as getting a centre for stem cell treatment for MS in Ireland. It'll probably be in Vincent's, that's where it's most advanced, but still ongoing process to try and get this up and running. So no matter what drug you go on, there's follow-up required. Now, follow-up in clinic. Our MS nurses are very central to follow-up, obviously, with a telephone advice line, follow-up MRI scans, follow-up blood tests. And then there's the concept, again, which, again, they like putting catchy sort of titles on it, but you can get progression in the absence of relapse activity, or PIRA. That's just another way of saying what we kind of know all along. There's a concept of smoldering. Whenever you go to MS meetings, they talk of smoldering MS. It's the sort of same thing. There's MRI sort of findings that can be associated with this. I suppose, maybe the big difference between now and 20 years ago is that we're more active. We're obliged, not obliged, but it's the right thing to do, to follow up with MRI scans, and not just clinical, but clinical is still probably equally and more important. Again, follow up to other symptoms of MS. As I say, these are often the unseen symptoms. And I have lots of people who come along and they walk into the clinic. They don't seem to have any problems with walking or the usual vision, bladder, bowel, everything is fine. But they're plagued with fatigue, So, and that it's a special sort of fatigue for MS, and we'll talk a little bit about it, but it's a topic in itself. There's other therapies then for MS. Fampira, for example, or Fampridine, it can improve walking in MS. And again, this drug would not be used if your baseline neurological examination is normal. It's a complicated reimbursement process in it, PCRS, which is a primary care reimbursement service. And this particular reimbursement process caused a lot of grief over the years, unfortunately. Botox can be used for spasticity in big muscles and for spasms. Medical cannabis, it can be helpful sometimes for pain and spasticity in MS. In order to get this is another sort of PCRS reimbursement process that you have to go through, and you have to fail, quote unquote, the other sort of usual drugs for spasticity like baclofen, Xanaflex, etc. And then vitamin D, I should mention that because a baseline, we should be treating everybody with vitamin D. How much to give is a question. We're not entirely sure. We do check vitamin D levels, obviously, but even when your vitamin D level is normal, we usually like to give vitamin D as well. Okay. Obviously, physiotherapy, occupational therapy, speech and language therapy, these are all important. Again, I mentioned in Sligo about the MS Centre. Obviously, physiotherapy centres around the country in primary care, health centres, very important to keep physiotherapy going. Occupational therapy as well, and sometimes speech and language therapy are necessary. They may have swallowing difficulties, etc. Don't forget bone health as well, because with MS, if your MS is advanced and your mobility is poor, then you're at higher risk of osteopenia and osteoporosis. And then general health management as well. I'll just mention a little bit about fatigue, and again, without being comprehensive, as I know about my print size difference from slide to slide, but I hope you can read that. So MS, fatigue is a very, very common symptom in MS, and I think if a person doesn't volunteer it at clinic, it's because you haven't asked them about it. But most of the time, people will volunteer it because it can be very, very disabling. Along with cognitive function, I suppose, which is again an area of it's not inevitable cognitive dysfunction, but cognitive dysfunction is still common in MS, especially more advanced and progressive MS. it's interesting that fatigue, along with cognitive dysfunction, is the most common reason for early departure from the workforce in MS. You would think it more, maybe your legs are too weak to work, but it's actually these two symptoms. It's quite interesting. Fatigue is easily misunderstood by family members and others, the rest of the world, as laziness or disinterest. And it has many determinants, for having said that, like sleep, mood, other drugs, etc. It's important to pace yourself. Again, what that means, in effect, sometimes we use medications to help fatigue in MS, like modafinil, which is Provigil, which is a drug used for narcolepsy as well, and amantadine, venlafaxine, adjustment. And again, you may have to make adjustments for fatigue in your at work and at home. Managing bladder dysfunction, and you can either have a sort of irritable bladder almost, the urge to go even with small quantity of urine, so you can get urgency, frequency, sometimes incontinence, and nighttime, you can get people plagued having to get up 7 or 8 times at nighttime. The treatment for that is, we use medications a lot of the time. Botox as well can be used in that situation. Pelvic floor physiotherapy is important as well. And then if there's emptying bladder problems, possibility of intermittent self-catheterization. Managing bowel problems, constipation is very common. Sometimes you get overflow diarrhea, so it's not really it's still a constipation problem rather than a diarrhea problem. Again, adequate fluid, fiber intake, exercise, over-the-counter preparations, and you have all the various laxatives, etc. I'll just mention, because this is an overview, I'll mention something about diet, because we're not asked about diet that much, and we don't offer too much advice about diet, but there has been a few MS diets have been put out there. Don't think there's any real definitive evidence about this. There's no single MS diet proven to treat MS. There's a question of anti-inflammatory diet using leafy greens, vegetables, and berries. Olive oil, again, is another one. We talk of a chicken, so-called lean protein rather than red protein or red meat. Vitamin D, omega-3 fatty acids. There was this swank diet. Again, I should know more about it, but I don't. It has come in and out of flavour over the years, low saturated fat with high fish consumption. There's this overcoming MS diet as well, which is, again, a plant-based with seafood and tends to exclude dairy and egg. And again, a modified Mediterranean diet. That's what we're all supposed to be taking anyway, I suppose. In general, a healthy diet. So I haven't any answers for diet, but I'm just bringing it up. Exercise then, obviously, depending on your level of ability. Aerobic exercise, walking, swimming, exercise, bike, strength exercise like lifting weights, etc., flexibility and balance, yoga, Pilates, etc. Again, in conjunction with physiotherapy very often. So all these are very important as part of I should mention sort of maybe psychology, neuropsychology, etc. Unfortunately, it's a big deficit as well in our treatment armamentarium, so to speak. We have a deficit in psychological support, which is also necessary. And I suppose we do, in effect, MS nurses are pretty good at providing sort of unofficial psychological support. So there's, just with regard to, for a conclusion, and I have no idea what time it is now. 12:05, right? So I'd be eating into my colleague's time if he was here. So there's a lot of variability in severity with MS. I suppose the bottom line is early effective treatment is recommended, ongoing review of treatment, clinically MS, multidisciplinary input. We should try have a patients with MS-centered service, and as I started saying, we had Brain Awareness Week last week, but we need more resources in this part of the world. There's now, at this point, we have 3 neurologists, all based in Sligo, and we come 3 days a week to Letterkenny. Letterkenny has its own locum neurologist at the moment, and we're hoping that in time we'll have a permanent neurologist here, and there's approval for a second one. It's the classical HSE. That's approved. Oh, by the way, there's no funding. So this is what we have to deal with all the time. So we should be pushing to get that second person advertised and appointed as well. The first position will be interviewed for shortly, definitive post, in other words. And there is another which is not directly relevant, but there is a memory neurologist going to be starting here as well. But that person's job is targeted to memory, Alzheimer's, dementia, and officially don't have a remit outside that now. It'd still be helpful to have such a person. I'm sure they'll see some people with headaches, etc. So we do need more neurologists, again, without sounding like the Healy Rays. Why is Dublin getting everything? There's definitely more neurologists in Dublin I was on my own for nearly 10 years, and there was no place supposed to be on their own. No centre should have neurologists on their own, but the growth of neurologists in Dublin, and again, I'm not saying they have too many, it's just we don't have enough here. And on that note, thank you for your attention.
Thanks very much, Dr. Murphy. I'm sure you all have loads of questions. So could I ask you maybe to put your hands up, and we'll get to you with a roving mic, if there's anyone. Okay, thanks, Aoife.
Yeah, thanks very much for all the information. I was just asking around, I came up on a previous slide, around the cancer screening.
Yeah.
I hadn't heard about that until today. Could you give us more information on why? And
it's more, well, I suppose, especially for more the highly active drugs, as we call them. Yeah.
Can you name them, or
ocrelizumab, natalizumab, but fingolimod, all those. But what are the cancer? There's basically a cervical check, breast check, in the appropriate age group, the bowel screen. That's about it.
So is there evidence to say there's a higher risk?
No, it's probably general attention to health before we put you on these. No, it's not a higher risk, no.
Okay, so it's just a general
screening. The higher risk, they talk of cladribine, but the data, it's got out there that cladribine, which is Mavenclad, that there's a higher risk of cancer, but I think if you look at the data, it's actually, there was a delay in bringing out this drug initially because they looked at the placebo arm versus the treatment arm, when they do these studies, right? Sorry, can you hear me? But in the placebo arm of that, there was actually no patient with cancer, which is a freak, That was a freak and the conclusion is there's no real increase in cancer risk with that drug. But the others is just general attention to good health and good health practices.
Okay.
Yeah.
Thank you.
Hi, Dr. Murphy. I'm just a question in relation to if you have children. I know you had a slide there, but what is the risk of them developing MS? I know that's like asking.
Yeah, well, I think there is a slight increase, but it's not inevitable, obviously. Just as if you're from a family of 10, you had 4 siblings, it's not inevitable you're going to get it. Mm-hmm. So that's all I can say, really. I generally, this is unofficial, but I would generally advise parents or people who have MS, who have children, maybe you should give some vitamin D, Yeah. But what dose or what, you don't know, And sometimes I suppose people, understandably, they're concerned for their children. They might check vitamin D level, but it's not full. Vitamin D is not the full story, definitely.
No.
But I think it would be important. Yeah, that's what I would recommend. But again, it's very unofficial advice. There's no public health policy on it, for example.
Okay, so like if you have our middle son is 18 now, but he would have fatigue and muscle aches, things like that. But
Yeah.
nothing otherwise. So it's probably just me zoning in on sort of things that I would have had.
Yeah, well, I say the thing about fatigue, while it's a very prominent symptom in MS, it's very common as well, you know.
Yeah.
And we've had an epidemic of fatigue, of course, with COVID, you know, and the post-long COVID syndrome, and which has been quite prominent. So I think you'd have to, with fatigue alone, look, I suppose if I have people coming to me, my child is very fatigued, I have MS, you know, you'd have to assess
Why? Yeah.
your child first and say, have you any other symptom, like, you know.
Okay. Yep. Perfect.
So.
Thank you. Sorry, Dr. Murphy, I'm just going to bring up a question that was sent to us in advance as well. And it was if you could make a comment on essentially any of the kind of emergent treatments and how close we might be to medications that would help to not only halt the progression of MS, but maybe help to undo some of the damage.
Yeah, well, sorry, I didn't bring up this. When you go to the MS meetings, there's always sections on so-called remyelination. There's nothing definitive out there yet. I don't. I'd have to remind myself even at the meetings what those drugs were, because it's very advanced, sort of, not in my day-to-day practice. So I think you're talking of remyelination, and then prevention. The area of prevention could be possibly a vaccine against Epstein-Barr virus. The remyelination therapies they're still at a sort of a research basis. There's a Bruton kinase inhibitors and a group of drugs that are probably going to come out as treatments in the next few years as well.
Great, thank you.
Hi, Dr. Murphy. I was just wondering, why is it that when you're diagnosed with multiple sclerosis or any autoimmune disease, do you tend to get things like fibromyalgia, chronic pain syndrome, FND, all these other illnesses kind of come with it? Why is it so common?
It's a complex question. Yeah, I don't think. Well, I don't think. You mentioned FND, which is functional neurological disorder. I mean, that's fairly common out there in the population. So I would say there's no particular reason why people with MS would be at risk of that as well. You know, it's just you just happen to have two common conditions. Now, I think your other question about pain and that is interesting, because obviously
the fibromyalgia or chronic pain syndrome.
Yeah. I mean, pain is very often, it can be a feature of MS as well. I mean, probably some of you are familiar with trigeminal neuralgia, for example, you know, which can be very, very severe and very disabling. And it does occur in people who don't have MS, but it's almost, if you have fatigue and trigeminal neuralgia, for example, you should definitely look for, you know, have you got MS? You know, even if you have no other overt motor, sensory, bladder, bowel, or visual symptoms. So I think certainly, yeah, there's neuropathic pain. I suppose that, again, you can assess the nature of pain. Is it neuropathic pain? Is that different to fibromyalgia? It is very often, and it's all in the history of what type of pain it is. You know, a burning pain, the trigeminal neuralgia is the stabbing, lancinating, you know, that sort of severe pain that you get. So again, I don't think there's any evidence that FND is more common in people with MS. It's just, unfortunately, a common condition as well, and it's a whole other talk, obviously. I don't know if that answers it.
Yeah.
Or partially answers it, anyway.
Thank you. Making my way over to Pat.
Using this, Dr. Murphy, how are you? The two questions. One, you raised on one question about brain, and I didn't hear it, about the various difficulties about the brain and the complications. I know you raced down it and I didn't hear it.
About what, sorry?
You went down the line of different things that could be affected, and one thing was about brain. And I know there's brain confusion or
brain fog, is it?
Brain fog.
Yeah.
What's that?
Us brain fog is kind of you think your thinking isn't straight, or you're difficulty concentrating. You know.
Okay.
Is cognition, or your thinking is slowed, or again, it's a common symptom out there in the general population. It's also, with long COVID, for example, brain fog is a prominent symptom, and fatigue.
Right.
Yeah.
And the other thing about brain, I've got epilepsy myself and MS, and it's that relationship between the two. And is there any complication between both of them and using the same medication?
Well, I suppose, first of all, brain fog, cognitive dysfunction, problem with thinking, concentration, memory, all those. When you treat, they can be part of MS, generally maybe more with progressive, as time goes on, less so than at the start, maybe with relapses and that. So when you treat relapsing remitting MS with any of the drugs that we mentioned there, that tends to be for the physical side of things, the mobility, physical relapses like optic neuritis, myelitis, cord involvement. It's generally maybe not as effective for things like fatigue and brain fog, but that's not always the way, So I think you treat these symptomatically. You give the disease-modifying drug and hope that will help them. But there may be things like fatigue and cognitive dysfunction, cognitive brain fog, difficulty with concentration, etc., that may not be helped as much, and therefore you have to specifically target those symptoms of like fatigue and brain fog with specific support, or what we call supportive treatment, rather than, you're not going to cure them, but you might help them.
And see, with the epilepsy and MS.
Yeah.
And is it becoming more common?
Yes, it is, unfortunately. I suppose you get what we call symptomatic epilepsy. I think the figures show it's about 5 times more common than the general population if you have MS. I suppose the reason is the multiple sclerosis is another word for scarring, if you like. I know it's not a nice term, but so scarring of the brain for whatever reason. You get it post-traumatic, post-meningitis, post-operatively if you've had a brain operation. That is a risk for getting seizures. And just because in multiple sclerosis there can be multiple scars from the MS, then your risk of of epilepsy is about 5 times, in general about 5 times higher.
Right, so there is a relationship between getting MS and then because of that you can get epilepsy?
Yes.
Right.
Yes, that's it, yeah. I mean, I have seen 1 or 2 people that have presented with a seizure, and, they had no other symptoms of MS except when we did the MRI scan, there was MS-like activity on the MRI scan. So it can happen, it can occasionally, uncommonly, but it can occasionally be the first presentation or first symptom of MS.
At the national conference, possibly 2 years ago, there was a neurologist from St. Vincent's down, and he was speaking that they're studying about sinus problems with MS. Is there any more?
Which sinus?
Yeah, sinus.
I'm sorry, I'm not familiar with that.
That's all right.
Hello, Dr. Kevin. I've met you several times. My name is Mary Heavey. I'm from Ballina, and I attend the MS Centre in Sligo. And I want to thank you for always being so interested in turning up to these events. It's wonderful, because I know you're a busy man. My first question really is about, You mentioned about TB earlier on, and this is something that's on my mind for ages because I have a connection with Donegal, first of all. My father was from Donegal, and he had TB when he was young. And I often wonder, is there a connection with that? And you mentioned that there might be somewhere that we can check that out. Is it in Sligo? Can you get a test done or something in relation to see with blood tests, whatever? Could there be anything there that would have caused mine? I've remitting relapsing MS.
Yeah. No, there isn't. I mentioned TB as a bit maybe like the cancer question earlier. We screen for TB, you know, and you should be involved in cancer screening programs before we put you on these higher order treatments. So there isn't really an increased risk of it. So that would be what we do. What we do, we have come across in some patients, you can get what we call latent TB, you know, which is pretty common probably in the older age population, maybe 60 plus now, you know, from the time that TB was endemic in this country. So you do what we call a quantiferon test. And if that's positive, we generally might repeat it to make sure it's positive. And if it's positive, then we have a discussion with the patient about possibly going on treatment for 4 months with anti-TB treatment. But they may have no symptoms of TB. Would we, because it's positive and we're going to put them on immunosuppressants, you know, we said we should also treat for that latent TB.
Yeah.
And we would, yeah, I mean, there is in theory some of the drugs could unearth latent TB so that you become overtly symptomatic with TB, you know. But it's not really a big issue, and certainly the TB doctor, TB specialists tell us that, yeah, well, you can start the treatment for MS and you can, you know, treat for the latent TB later, you know.
Yeah.
Because if you start a drug like ocrelizumab or anti-TB treatment at the same time, you know, you have, and your liver function goes off, you have to make sure, you have to know what's causing that liver function to go off.
Yeah. Yeah, well, and as well as that, I know I've brought it up several times at different occasions of these conferences. Is there any way that any of us can be tested? It's probably not your work, but you know, just to see, is there anything possibly that we had or did or our parents had or whatever that brought it on? And as well as that, the next part of that question is, well, that you've already spoken about it, because of the prevalence of it in Donegal in the northwest, that it's really an epidemic. It's so serious. It's really serious. There's so many people with it and so many more people being diagnosed with it, that if it was any other country, they would really treat this as really extremely important, and they would say, we must address this, we must get more neurologists, we must campaign for it. Now, I know I recently campaigned for that a few months back, about 6 months ago, and to get neurologists, one in Sligo, not Sligo, sorry, SU, Castlebar and Letterkenny and all that. But they're slow to start up, and I know they need help. My own neurologist has always said that. But we should really, really jump on this one big time.
Yeah, I agree. But there's no, are you asking about screening for MS?
That's my first part,
Yeah, like, I don't think we've reached the stage where we should get an MRI, and like, if you want, the screening would be an MRI, but like, are we going to have a policy to MRI everyone from the age of 16?
As a matter of interest, Do you know what I did? I had an MRI done recently, and I have it now 25 years. And I was MRI'd originally when I didn't know what was wrong with me. And they brought my scan with me down to Sligo. There was no neurologist there at the time. So my original scan is down there, or whatever I brought with me, is in Sligo. So I wonder, can I get my hands on that, because they want to compare it. They were saying we need to compare this latest one to see what your scarring is, because at the time they said it's not that bad or something.
Yeah,
I don't know how. I'd be asking you, if you're around later, can I ask you a little thing? Who do I ask?
We have problems getting scans back. Everything went the electronic route, if you like, from 2011, I think. And scans before that, it's now a big job to try and get our hands on those. You know, the old ones were big. You'd look up in the light and look through the board. So yeah, I don't know if I can help you with that one. But I think screening I think from a population level, screening, doing an MRI on everyone at the age of 16, like, I don't think we're going to, I think that would be very costly, number one. I think you'd pick up some incidental findings as well. I suppose in the absence of that is probably, investigation of symptoms and get a diagnosis as soon as possible. What we don't know is if you present with optic neuritis, say today, and you do an MRI and you see all these, what we see on an MRI scan with the lesions. What we don't know is if we MRI'd you 5 years earlier, would we have seen anything? For whatever reason? We don't know that. And I've had patients as well. I've had a woman that, in retrospect, she came in with an optic neuritis, and there was really nothing on her scan, and comes in about 2 years later, and our MRI has totally changed, So we could have been sort of semi-reassuring her 2 years previously, yet reassurance wasn't the right thing, as it turns out with her. She's doing okay otherwise now at the moment.
Dr. Murphy, you touched on fatigue there. And from a point of view of a person living with someone who has MS for the last 42 years, we never could understand fatigue until we met a neurologist back in 2004. And he said, unfortunately, rest doesn't take it away, which it didn't. But the only thing I found from living with the person that brought her, when she had a rest, her humour improved. Whereas if she didn't have a rest, the humour was very difficult at times. And talking to other people that have MS, that's the only thing that seems to be in common. Everybody has fatigue. They mightn't have the same symptoms, but they all have fatigue. And just from the point of view of living with someone with MS, rest was the one way of trying to cope with it. And it improved the attitude towards everything after that,
Yeah. Well, if you've ever seen a rheumatologist, they'll tell you rest and exercise, You say, well, which one do you want me to do, rest or exercise? So it's a bit like that for the fatigue dilemma. I mean, rest is important, but one of the issues is because of your fatigue, you can't do anything, But I think there's definitely the evidence points towards that fatigue. The approach to fatigue shouldn't be rest alone. Obviously, you have to take your level of ability into account, how your MS has affected you, but definitely physiotherapy, exercise is important as well.
Yeah.
So I can't answer that question really. There's other things, fatigue can be associated sometimes with mood disorders like depression, anxiety, and I think you have to also treat those or try and help get those treated as well. So it's, as I said, the approach to fatigue is really,
Okay.
Different ways to approach it, or a multi-modal approach, if you like.
Thank you, Dr. Murphy. Just on my way over to somebody else now, but in the meantime, somebody has asked as well, is everybody screened for Epstein-Barr virus when they're diagnosed with MS?
No. This is kind of academic. A lot of people, we're going to have positive. It's a bit like, it's not going to affect management at that point. About half a lot of the population will be positive for Epstein-Barr anyway, So we're not. It's not. No.
Hi, Dr. Murphy. My name is Mark Early. The one question I had was, all the stuff I've read so far is that MS is not a hereditary condition. I have one mate in the UK. We've had very similar environmental exposures throughout the years through working in the military. However, his mum is a 40-year veteran of MS, and he ended up getting MS 1 year before I did. Has anyone looked into doing research since on whether it is hereditarily disposed or?
Yes, there has been genetic studies. Yeah, done quite a few of them. There's nothing straightforward coming to light. I think we know from just observation that there is a genetic element, and we're not denying that. Sorry, if you can hear me. We're not denying that, but I think probably if you pitch genetics versus environment, it's probably more environmental than genetic. But it's not to say there's not genetic elements. There's certainly that's about all I can say. Like, you know, the studies have looked at it, and it's called what we call polygenic, which is another sort of fancy way of saying, you know, we don't know. You know, there's no gene coming to light the same as they have with Huntington's chorea, for example, Huntington's disease.
Okay.
Yeah, but you know, and obviously environmental exposure. You know, we're all born. If you're all born in Donegal, you know, you all have approximately the same environmental exposure.
So I can't say quote the source, but there was also mention maybe in the last 6 months that Donegal, Leitrim and Sligo had actually the highest incidence of MS, not only in Ireland but in Europe. Is there some credibility to that statement?
I don't think it's certainly the highest in Ireland, and I'd say across Donegal, the rest of north of Ireland would be high. Scotland, I think the highest incidence. Again, I haven't reviewed that recently. Traditionally, when I was growing up and reading and hearing about it, the Hebrides, I think, in Scotland was the highest. But I'd say definitely within Ireland there's a gradient, a north-south gradient. We say, like, I'm from Cork, there's lots of MS in Cork. So it is, Ireland as a country as a whole is a relatively high incidence, but within the country is higher in the north. So there is a gradient. Temperate climates, it's the same in the south, like New Zealand, similar sort of. But yeah, and as I mentioned, Michael Hutchinson's study from 30 years ago, that was the highest incidence in Donegal. And again, the vitamin D studies have paralleled that. And also, I suppose I should mention, there's suggestions socioeconomic factors as well. You know, whether that's...
Thanks very much.
Yep.
Thank you. And we have another question that had come in earlier. And the question was, for patients currently stable on treatment, what factors might lead to recommending switching treatments?
Switching treatments would be intolerance or side effects of the treatments, if you're stable from a neurological point of view. That would be the main one. There is, and again, I didn't bring up this topic about possibly discontinuing treatment, which is, I don't think there's any consensus on that among the MSologists in the world, but there's certainly a lot of talk about it in recent years. So generally, there is the concept of immunosenescence, which is basically your immune system goes that way as you get older. We referred it in one of the slides, but so we're maybe a bit more anxious about continuing drugs like rituximab, ocrelizumab, those anti-CD20 drugs, for example, in the older age group. But depends. I think all this depends on how we define old. And if you have a healthy 75-year-old and they're on treatment and doing well, you know, good luck in trying to, you know. So I think.
It's another wee genetics-related question. We have a prevalence of hypothyroidism in my family. I have it, my mum has it, my sister has it, my aunt has it. Does that increase my daughter's genetic predisposition to develop an MS in the future, or is it just like a byproduct of that?
Yeah, well, you talk what condition you talk about? Hyper?
If I have MS,
but
yeah. I also have hypothyroidism.
Hyper, is it?
Yeah. And then my mum has it, my sister has it, my mum's sister has it. It runs in our family.
Yeah, they have hyperthyroid.
Yeah.
Overactive thyroid.
Yeah, no, under, hypo.
Hypo,
right.
Yeah.
So does my daughter being genetically predisposed to hypothyroidism, does that increase her genetic predisposition to develop an MS because I have MS?
I think your daughter's predisposition to MS is slightly higher because you have it. Mm-hmm. Obviously, I can't really comment on the hypothyroid. It depends on the cause of it. You know, again, thyroid problems are very common, like out there in the population.
Ours was all triggered by pregnancy.
Sorry?
Ours was all triggered by pregnancy. We didn't have it until we were pregnant.
Yeah, and well, that's I can't speak to what process is involved there. It could be. there's some thyroid problems that are autoimmune, like Hashimoto's and Graves' disease. You know, Graves' disease is usually overactive thyroid, but it can burn out to an underactive thyroid. So again, I'm spoofing here. but no, Graves' disease is an autoimmune condition. So it's one, like, having one autoimmune condition predisposes you to another, you know. So if you had Graves' disease, for example, then maybe your daughter would be at increased risk of Graves' disease as well.
Okay.
You know, and I'm not really I'm indirectly answering your question, but because you have MS, your daughter has slightly increased risk of MS as well. So maybe the two things together, is that what you're thinking?
Yeah.
Again, what to do? I'd probably put her on a bit of vitamin D and you know, tell her don't worry about it.
No worries.
Thanks. Good girl. Thank you.
Hi there. I have a question regarding stem cell therapy. So, assuming it is becoming a little more common within Ireland to be referred to England for it, I was wondering what your opinion is around the safety of it.
Yeah. Well, I think stem cell treatment maybe 10 years ago was being held out as maybe everyone should have it. You know, it's possibly a bit less enthusiasm for it. Since then, that's my impression. I think it's safety. Obviously, there's a whole process you go through, and I'm not involved in the process itself. You know, when you go to London, or if you go for a stem cell treatment, first of all you fry your bone marrow, so to speak. So you need to be barrier nursed in an ICU sort of setting, even more so than COVID. You know, this is strict barrier nursing, because if you get any infection at all, it could go through you, and you have to get that's for a few weeks, and also your platelets can go low. You know. And there was I've heard of a case of someone who fell and hit their head, you know, with low platelets, and it was a bad outcome, unfortunately. So it's like you're going through a hazardous journey to get to the promised land of, you know, you now have your MS treated for good, so to speak. So I don't think to stop me from in referring the appropriate people, you know. Now I think the thing, you fail one higher order treatment, as we call it, and you would consider for stem cell treatment. And again, it's like a discussion with the person in front of you who has it. Like, you might be a candidate for stem cell. What do you think of it? Like, there are some people who are chomping at the bit to get stem cell therapy. There's other people who say, I don't want to go near that, you know. I suppose it depends what you hear about everything. So I can't give you exact figures, but in general, though, you know, you'll hear the horror stories, but people do get over it, you know, and it is definitely the advocates of it who work in the centres see very good outcomes, you know. But we also see very good outcomes in the use of Tysabri, natalizumab, you know. But I suppose it's the long-term use of that treatment, you know. That's one of the issues I suppose I didn't discuss. If you start treatment and you're at 20, you know, are you still going to be on that treatment when you're 50, when you're 70? Yeah. So I mean, that is why it's all an evolving sort of situation. You have to keep it's continuing follow-up. We don't have all the answers now, you know. Yeah. So that's kind of the way I put it. We certainly would consider it. Yeah, we have discussed one of our own patients at our national meeting. I haven't referred anyone personally, or from, I think, my colleagues in Sligo we haven't sent anyone. We've discussed a few, but I've had one or two people who've of their own volition have gone off, one to India and one to Mexico, I think, and got their own stims and paid for it themselves.
Anybody else with questions? And I have just one. Who's first, by the way? Just with regard to what's coming down the line with subcutaneous Ocrevus infusions, what are your thoughts on subcutaneous Ocrevus infusion versus the current regime of Ocrevus infusion IV, intravenous?
Yeah, I mean, I will sort of tend to believe, but not be totally gullible by what you hear, but I certainly would discuss it with all the people who are on the IV ocrelizumab or Ocrevus and say that there's a subcutaneous option available now. I tend to be a bit conservative in that if they're doing well on IV, and there's a certain, it's a bit, we had this with Tysabri as well, because Tysabri is available subcutaneously for quite longer, but people with ocrelizumab, they kind of like coming and spending the day, so to speak, getting their treatment, and they say, oh, it'll only be half an hour now, because it's one injection, half an hour later, another injection, on your way, you know. There isn't enough time for them like to sort of review how they're doing, you know. So, but definitely it will be, from an administrative point of view, it's going to be very useful, because we have a pressure on our infusion unit in Sligo, and recently, the good news is recently we went from a 2-bedded room, if you like, down in Medical 5 down in Sligo, to an infusion. We've got an infusion room. Now the problem is there's about room for 5 people in the infusion room. We don't have the staff to go with it, so we're promised the staff. So hopefully we're going to get pushed that. But yeah, I'd have no problem. The easier it is for the person, the better. Yeah.
Hello, Dr. Murphy. Thank you for being here today. I just have a quick question personally. What would you suggest, or what would help with neuropathic pain?
Oh, that's a...
I know it's a bit of a word.
I think you'd have to individualize it and say where is the pain, what's the nature of it, how often is it there, etc. In general, for pain, there's acute painkillers, and then there's pain prevention, preventative therapy. So I don't know if I can be any more specific than that. And of course, there are pain services as well. Again, more honoured in the breach than in the observance, as they say. You know that we often have unfilled positions in pain services. But the neuropathic pain, you know, anything that works from the point of view of acute pain, you know, paracetamol, I'm not suggesting paracetamol, right up to morphine, if it came to it. And then the pain prevention, you know, there's loads of things, loads of drugs we can use. There's a whole list of them. I don't want to go through them. But sometimes in MS, for example, if you have neuropathic pain and fatigue, you can look at a drug, possibly like venlafaxine, I mentioned that there, which could be a sort of a 2-in-1 and help both. But it can be a difficult area. There's also pain injections that people get. Trigeminal neuralgia, for example, you can get injections and stereotactic radiosurgery up in Beaumont. So there's you could write an essay on that question, I suppose. Yeah.
And I suppose, does an MRI, would that help to sort of help on what's the best option to take?
Usually the MRI isn't that helpful because there is no real correlation. If it's MS related neuropathic pain, then it can happen anywhere, and the MRI doesn't really help. You know, it's the location of the pain. You know, you can get burning feet or burning legs, for example. You say that's probably coming from the spine of their MS, which might be involved. Trigeminal neuralgia, likewise. You know, you might look at an MRI to see if there's any other cause of the trigeminal neuralgia, like a blood vessel or something irritating that nerve. But generally, no, it's a clinical thing primarily.
So would you suggest just to talk to your consultant?
Yeah, exactly. Or GP to start with, if you want.
Okay, thank you.
Thank you, Dr. Murphy. Carrying on from the neurological pain, what's your opinion on gabapentin for neurological pain? Because I've seen research online recently about it causing early dementia, especially in women, and brain fog. I know brain fog comes with MS and other medications, so should I be worried about taking gabapentin?
Well, I haven't. I must say I haven't heard the research about dementia.
Yeah, I had a GP that I had said about it, because I haven't seen my neurologist yet since I seen the article, and he was like, don't take that, I hate that medication. So I was weaning myself off it, lowering the dose, And then the neurological pain was coming, so I was like, right, I have to wait now until I go to see my neurologist about it. But then the worry of early dementia and the brain fog getting worse, I don't know if it's that or MS.
Yeah, I don't know. I have to say, mea culpa, I haven't heard that association with... I would have felt personally that pregabalin, which is Lyrica, would be sort of a stronger one associated with brain fog and things, rather than gabapentin. I would regard gabapentin as sort of Lyrica light, if you like.
Right, okay.
And so I would generally tend to use gabapentin myself ahead of pregabalin, which is Lyrica.
Right, okay, great.
So that's what I would say. There was a study came out. There was like you take a drug like amitriptyline, for example. You know, familiar with amitriptyline? That's used for neuropathic pain as well. And something came out years ago about that being associated with dementia as well, but nothing came of it really. You know, as you say, cognitive fog or brain fog and MS is a complicated. It's the MS itself. It's the medications you're on, maybe. Mood issues, everything. So there's multiple factors involved. Yeah. So I think you have to address.
Sorry, I just have one more question just in relation to treatment. So when I got diagnosed 23 years ago, I obviously I was a lot younger, and I was put on Avonex, and I took that because it was once a week, but then the side effects were really bad with the flu-like symptoms, and then fast forward to maybe 10 years later, I was put on a different interferon, and the side effects were even worse, and then now I take Copaxone, and I've been on that for a really long time. Is that safe to keep taking whenever your symptoms are?
Yeah, as I say, if we diagnose you if you came into, if you were 20 years younger now and you came to a neurology clinic, they probably wouldn't be putting you on Copaxone or interferon.
Yeah.
But I want to emphasize this: there are people on these drugs who are doing very well, and I don't change it, because if you're doing well on it, why change it? You know.
True.
I have. So yes is the answer. It's okay to continue it. You know.
Okay. Yeah.
You're monitoring clinically and by MRI, as you know.
And how often then do you recommend MRIs to be done when you're on treatments?
I'm not going to answer that one. I'll be held to account.
Yeah. Fair enough.
Yeah, I suppose with certainly for the drugs like Tysabri, natalizumab, you know, you're really obligated to do an MRI every 6 months or every 12 months at the outset if you're seronegative. For a drug like Copaxone, probably every few years, I would say.
Okay. Just one last thing. So whenever I got referred to you from my neurologist in Galway, and I was having like sort of more sensory, like pins and needles relapses, that sort of thing, and he had recommended to put me on Tysabri, and then I came to you, and you were like, I never heard of the JC virus before or any of the complications. So if I had been still in Galway, I think that doctor would have put me on the Tysabri.
I think
that was
in fairness, it may have been at a time where the JC virus wasn't to the front of consciousness about. It is like, we have taken a lot of people off Tysabri, so you may well have been put on it and taken off it, you know. So we've taken people off Tysabri, even though they've done well on it, because we've had to.
And I don't think I was ever bad enough to be put on it, if you know what I mean. So
that's again, that's that's debatable. I mean, we look at MS from the point of view of clinical, obviously, and we just say it's quote unquote only sensory symptoms, but they can be very disabling as well, you know. And also, of course, we can have people with minimal symptoms and their MRIs look terrible. You can have people with MRI doesn't look too bad. You've only, you know, you do have MS, but you don't have too many lesions. You don't have cord lesions, but they're very bad clinically, you know. So there isn't a straight line relationship between the MRI and clinical. And so in the end, you come down to individualize it each time. And that's why it's under review. If you were put on Tysabri in Galway those years ago, you know, I'm sure there's not bad neurologists in Galway. There would like keeping people under review and always saying, will we continue this treatment? You know, should we change it? You know, some people come along and say, I want to stop it. You know, they insist on stopping it. You know, so all that happens. You know, so the thing about MS is that we can't really dictate to people anymore. You go on that, like, you know, do what you're told. You know, it's no. There are some people who say, you tell me, doctor, what I should take. You know, and that's fine as well. You know, but it is a two-way discussion. Yeah.
I think we should wrap that up. We're coming up close to lunchtime, and I think Catherine wants to say a couple of words. Can I just say thanks? That was an incredible question and answer session. I hope everybody got something out of it. And again, please, a round of applause for Dr. Kevin Murphy. Thank you.
Thank you.
I'm not going to keep everybody very long because I'm sure people are getting a bit hungry and looking forward to lunch. So my name's Catherine Peoples, and I'm the Regional Coordinator for MS Ireland here in the Northwest. I know a lot of people here, but there's a lot of new faces as well, so it's really nice to see everybody here this morning. Like Maria and Aoife said earlier, I'd really like to thank Dr. Kevin Murphy for coming this morning. Because as we all know, anybody that knows Dr. Murphy knows how busy he is and what a heavy caseload he has. So we really, really appreciate him coming along. And his talk was really informative and interesting. And obviously the questions as well, you know, were very interesting. I'm sure people have hopefully got a lot of benefit out of what they've heard. I would like to thank Novartis, who funded this event today. Without funding, you know, we wouldn't be fit to run because obviously costs involved. I would like to thank the staff, our own staff in the Northwest office, Maria and Geraldine, who's at the registration desk, and Aoife Kerwin, our colleague from National Office in Dublin. Apologies for the bit of a change in agenda as well. We had Bill Vaughan on our agenda, but unfortunately, you know, just unforeseen circumstances this morning, Bill couldn't attend. But I think it gave us more opportunity to listen to Dr. Murphy, so it all worked out. I would like to thank the staff here in the hotel in the Clanree, especially Antoinette, who we've worked quite closely over the last number of weeks leading up to this event. Her professionalism and, you know, anything that was needed really, there was never a problem. And obviously to the staff here today as well that are putting out the food. Thanks very much. So maybe just to talk a wee bit briefly about what we actually do in the Northwest office. I think anybody that's here that knows us for a while, these glasses are for reading, so I can't see them when I'm looking out at these. Anybody that knows us in the Northwest office would have a good idea of what we do. But for new people here today, I suppose the main thing that we do from the our office is based in Ballybofey at the Butt building, the HSE building in the car park in Ballybofey. So we're very fortunate the HSE give us space there to have our office. So our main function in the office, I suppose, myself and Maria provide casework to individuals with MS and their families. And the casework really would cover any services that somebody needs. It could be very much, I suppose, important at the point of diagnosis, where people are obviously, you know, worried and concerned. They might have never heard of MS, would have no knowledge of it, and you know, to be told that they have this long-term condition can be frightening. So I suppose it's really important, I suppose, to get proper information and to reassure people, you know, as Dr. Murphy has said as well in his talk, that treatments and that are on board now at the moment, it's leaving MS, that it's not, you know, as daunting as it would have been a number of years ago when there have been very few treatments and supports there. So at time of diagnosis is very important, and then obviously throughout the journey of somebody's life with MS, we're there to provide any services, you know, again, entitlements and what they're entitled to, Then Geraldine would coordinate online services that we run from the office, physio, yoga. We have monthly online support groups. You know, what people find, it's really beneficial, I suppose, to get an opportunity to meet other people with MS and to share experiences and just get the support. I think, as Dr. Murphy said as well, you know, MS is individual to everybody. But when a group of people get together, like today, and get talking about their experiences and what they're going through in life, people would find that actually their experiences are quite similar. And the support that you get from that is really immeasurable. I think, you know, that's where we would organise, myself and Maria and Geraldine would organise groups where we take newly diagnosed groups away for maybe a night or two, couples, carers. And again, it's about giving them an opportunity to sit down and discuss their concerns and their experiences and go away from those events feeling supported and not as alone as maybe they were when they arrived. We also run a community employment scheme from our office. Kieran Carlin's the CE supervisor, and that consists of a number of community visitors and maintenance workers. And I suppose their main role is, you know, community visitor would visit people in their homes, bring vital information, and then obviously bring information back to us in the office. The maintenance workers would could be just basic, maybe a bit of gardening, bit of painting, maintenance within the home. So if there's anybody here that would feel that they would need either of those services, make contact with the office and we can arrange to, if we have somebody in your area, we'll try and get that done. We actually, as well, I suppose it's very important to say here today that we work very closely with the Donegal MS branch, which is a voluntary side of the organisation, and they're a fantastic group of volunteers who provide, you know, supports to people with MS, and we work very closely with them because without them, you know, they would fund a lot of our events and activities. They have social summer outings, they have a Christmas party, and they do a lot of fundraising, and any money that's raised would be then go back into providing support for people with MS that need maybe some financial support from time to time. So, and on that, their AGM is here actually in the hotel on Monday evening at 8 o'clock. So it'd be great to see more faces, I suppose, attending the AGM and getting involved with the branch. So like, if people have time on Monday evening, definitely come along. So I suppose you'll be glad to hear finally. I'd just like to thank everyone again for coming along and making this such a successful event. And just to remind you as well that there's information still at the stand coming in. Feel free to bring booklets home. There's myself and Maria's contact details on the stand. Because as I said, I would know quite a lot of people here today, but there's a lot of new faces. And for anybody that maybe it's their first time attending an event like this and they would like some contact, obviously it's confidential. Definitely feel free to pick up there's 2 business cards, one for myself and Maria. And they would have Geraldine's email from the office that would have been sent out information about this. Feel free to just pick up the phone, give us a call, and see how we can help. I suppose the main thing as well, if people would, maybe when after they're having their food now, take a wee bit of time and fill out their feedback forms, because obviously we organise these events and we think we're trying to fulfil what people need, but the feedback forms help us plan future events, and don't be afraid to put, well, hopefully it'll be positive comments, but don't be afraid if there's any suggestions or you feel that we could have done something different or you'd suggest doing something different for the next time. We welcome all comments. So without that, I think I'll let people just, unless there's any questions, I'll let people have their food in peace. All right, thank you very much, thank you.